Hey everyone, welcome back to episode 3 of Beans in Crisis. This time we're going to be talking about acid base, something that's very common in the ICU. And while this is often very foundational, the reason I want to bring this up is many critically ill patients are metabolically deranged. And oftentimes, getting on top of these acid base disorders is going to be critical for us managing patients, or at least foreseeing something's going wrong. It'll help us get patients out of the ICU quicker, it'll help them make them feel better, and it'll prevent complications before it gets out of hand. So this initial part is just an approach to acid base, which I think is probably going to be considered as very foundational for most people watching this, and then we'll get into some more of the ICU specific topics where maybe I can give a little bit of um, uh, extra guidance or sort of hints that might help make acid base a little bit easier or just really fine tune your care in patients before they get worse. So let's start with the approach. First is we need to know what the actual total state of the acid base disorder is, and that's going to be looking at the pH. This tells us what the emia is. So, for example, whether or not they have alkalemia or acidemia. Now, this only tells us the state of the blood, but it doesn't actually tell us the processes of the blood, okay? Meaning the osis that's going on, whether that's metabolic alkalosis or acidosis. And so following the pH, we're going to naturally try and figure out which of those processes are going on. And we start with PCO2 because this tells us if there's a respiratory acidosis or alkalosis, it's in line with the pH. And then afterwards, we look at the serum bicarbonate concentration because the serum bicarbonate concentration is telling us about the metabolic state. Now, this is the part where people oftentimes may stop here, but I genuinely do think it's important to understand or divide this a little bit more by looking at anion gap to determine if there is an anion gap metabolic acidosis or a non-anion gap metabolic acidosis or a combined. And how do I tell that? Well, I tell this, I like to try and illustrate it in the form of something that maybe all of us have seen, but it's not know its name, and that's called the Gamblegram. So the Gamblegram is this image that compares the positively charged molecules to the negatively charged molecules in our blood. And the majority of the positive charged molecules are sodium, and the majority of the negative charged molecules are chloride, but then there's a pretty decent concentration of bicarbonate as well. And this space that's not explained is what we call the anion gap. And usually this anion gap is somewhere between 9 and 16 on our blood BMPs, or 9 and 15 maybe for our BMPs. And this is where we get into trouble because we sort of just look at this number and we quickly review, is this a red number or black number, and then we sort of move on. But I think it's really important for us to understand how this anion gap is derived. So it turns out that sodium makes up the majority of positive charged molecules, but there are quite a few negatively charged molecules that are not chloride and bicarbonate. And the majority of this is going to be determined by our albumin, which is a largely negatively charged molecule. So albumin, though, is very fluctuant, especially in our patients in the ICU who often have failure to thrive or protein caloric malnutrition, and you see that albumin is not going to be necessarily normal. But say we have a patient whose albumin is 4 versus a patient whose albumin is 2, well, this helps us determine what the expected anion gap is. What we do is multiply the albumin times 3, and this should be your expected anion gap. So for example here, if we have a patient whose albumin is 4 versus a patient whose albumin is 2, we would expect very different anion gaps in these patients. And why is that important? Well, let's say you take a critically ill patient with an albumin of 2, and on one day their albumin, their anion gap is 7. Okay, good. We're trying to treat them. Maybe they're intubated, on a ventilator, getting sedated, and we're trying to get a hold of their possible septic shock or something like that. Initially, we think things are going okay, but then perhaps we start to see that minute ventilation is rising or something else is going on, or the patient's pressors aren't quite decreasing, and we see on day 2 that the anion gap is 11, and then and we sort of look at this and say, okay, well, it's still a black number, move on. But in reality, this is the anion gap starting to widen, especially when the patient's albumin is 2, their expected albumin anion gap should be 6, and this anion gap of 11 is suggesting that there is some buildup of some negatively charged molecule, such as lactate, that could be a problem here, or it could be due to diabetic ketoacidosis. And then because we ignored it on this day, the next day it's now, say, 16, and that's when we finally recognize it, but we've wasted 24 hours in the ICU without recognizing necessarily that something is going on. Well, and to be fair, you probably would have recognized it by other things going on. The patient's pressors are rising or the minute ventilation's increasing, but just want to say that we get BMPs very regularly on patients, and this is another very quick, rapid way to get on top of a situation by understanding that anion gap is going to be based off of the albumin. There are rarely situations where the anion gap is too low. Like, say, for example, you have an anion gap of, say, like 2 to 4 in a patient consistently. This should make you concerned that actually what's going on is there is a decrease in the serum sodium for some reason relative to your negatively charged molecules, and you may have a normal serum sodium because, again, this is not a very big difference than 6 in these patients with low albumin. But it could be, for example, because you have increased positively charged molecules in your blood, such as an immunoglobulin. And this might be a sign, for example, of having multiple myeloma or some sort of plasma cell dyscrasia where you're creating a lot of immunoglobulins. So just something to keep in mind. Okay, so we talked about how we calculate our expected anion gap, and how then we can determine whether or not the anion gap, if a patient has an anion gap acidosis, and how maybe it could be a warning sign for something to come. But after you get your anion gap, it's really important. This is the step that maybe a lot of us sort of ignore. So I'm going to put it in red. But this is the delta. Now there's 2 main ways of calculating the delta. I've never really liked the division method. I think it's just additional math for no additional and harder math for no specific reason, but the delta instead can be calculated through addition and subtraction. So what is the delta? If we go back to our Gamblegram, we recognize that we have the sodium concentration, we have the chloride concentration, the bicarbonate concentration. And when an acid is introduced into the system, for example, a lactate or a keto acid, what happens is the hydrogen will consume a bicarbonate in order to maintain the pH, and you're left with this negatively charged molecule, an anion. Okay? As this happens, our bicarbonate is slowly consumed, and this larger thing becomes your albumin plus your additional anion here, which may be your lactate or your keto acid, for example. This is what an anion gap metabolic acidosis is doing. Okay, but in your non-anion gap metabolic acidosis, right? For example, you have um, diarrhea or you're adding normal saline. In these situations, what's happening is rather than the anion gap enlarging, you actually have an increase in your chloride and a decrease in your bicarbonate, meaning that you're actually shifting this bar upwards a little bit. But the actual anion gap itself stays stable. So you're swapping bicarbonate and chloride out in order to maintain electroneutrality. Um, and that leads to a non-anion gap metabolic acidosis. Okay, so in one, you're actually introducing another negatively charged molecule to the blood. In the other, you're swapping the bicarbonate and chloride for in terms of electroneutrality in the blood. So what will this look like? Let's take a patient whose bicarbonate concentration is 11, their anion gap is 16, and their albumin is 3. First, we have to calculate our expected anion gap. So expected anion gap is going to equal 9 in this case, 3 times 3, right? However, this patient has an anion gap of 16. So if their anion gap is 16 and our expected anion gap is 9, that means there are 7 unexplained negatively charged molecules in the blood. That could be lactate, ketones, whatever it is, okay? Now, as we look at an AGMA, the negatively charged molecule takes over for bicarbonate 1-to-1. Okay, so let's pretend these negatively charged molecules weren't in the blood. What we would do is remove these negatively charged molecules from the blood and replace them back with bicarbonate. So if, for example, this lactate or ketone or whatever it was not in the blood, and we remove these 7 additional molecules, well, bicarbonate would go up by 7. So the new expected bicarbonate concentration would be 18. And so in this case, we see that the bicarbonate still remains low. If the bicarbonate remains low, that means that the negatively charged molecules that have been introduced in the blood do not take up the entire explanation for why the bicarbonate by itself is lower. And so what this means is that you must have a non-anion gap metabolic acidosis as well. Okay, so in summary, the delta-delta is where we calculate the difference between our current anion gap and our expected anion gap. And we assume these negatively charged molecules, if they were to be completely replaced with bicarbonate, we then look at that new bicarbonate number and determine whether or not there still is an acid-base derangement. If it remains less than 22, then it suggests that there is an additional process, or if it is greater than, say, 26, that means that there's an additional process the other direction. If it's less than 22, it suggests a NAGMA, and if when we add it back it's greater than 26, it suggests that there is a metabolic alkalosis. This is very common in our patients with OSA, OHS who have chronically elevated bicarbonate at baseline, but they develop, say, a lactic acidosis. So they develop anion gap metabolic acidosis. But when you add the negatively charged molecules back to the bicarbonate, it goes to a higher than 26 level because they're in their normal state of health. They have a compensatory metabolic alkalosis. Okay, so this is what the delta-delta does. The delta-delta helps us understand that there's multiple processes going on, like an anion gap or non-anion gap metabolic acidosis. The first scenario that we're going to talk about is the non-anion gap metabolic acidosis. I'm going to be very brief about this. We all have our mnemonic for how we think about non-anion gap metabolic acidosis. In the ICU, it's going to be most often one of 3 things. The first one is going to be too much normal saline. What does that mean? Well, we're giving some sort of chloride-rich fluid, introducing that into the blood, And so when we do this, the bicarbonate has to be moved in order to maintain electroneutrality, and so you get a non-NAGMA metabolic acidosis. The second one that we're going to see is diarrhea. And the third one that we're probably going to see is actually the beginning of an AGMA. Okay, and this is the one that I want to focus on most. But notice I haven't really talked about renal tubular acidosis. The reason being, renal tubular acidosis, while normally in a patient with NAGMA who's not in an intensive care unit, diarrhea and RTA are the two most common causes. Renal tubular acidosis is incredibly hard to call in a patient with AKI or severe CKD, and most of our ICU patients are developing renal injury or failure or higher, in addition to their acid-base disorders when they have them, and so it's incredibly difficult to call a renal tubular acidosis in those situations. And so we're going to skip talking about a renal tubular acidosis because I genuinely think that this is more of a nephrology thing. But I would like to just point out, please don't call someone a renal tubular acidosis if they have AKI or CKD 3B or less, maybe CKD4 if you're being generous or less, meaning that their GFR, if their eGFR is low, they can't get rid of acid, and it's really hard to tell if that's because it's a renal tubular acidosis or just because of kidney dysfunction. Okay, so we're not really going to talk about number 4, but we do want to speak about number 3 because this is a good segue into our next topic about in scenario 2 about AGMA. So why is it that NAGMA metabolic acidosis leads to a non-NAGMA metabolic acidosis in the beginning? Well, it turns out one way of thinking about every NAGMA metabolic acidosis is at the very beginning they develop a non-NAGMA metabolic acidosis. It's just that usually by the time the patients have come to us, they've already been captured or they're already sort of far in their process, and so the NAGMA metabolic acidosis has already occurred. Now, when we look at an NAGMA metabolic acidosis, let's take a specific acid here, such as lactic acid or keto acid, which then breaks into a proton and its conjugate base, A-. Okay, the proton will then do one of two things. It'll either bind a bicarbonate or it'll bind a buffer. And we have many buffers. The buffers are there to make sure our pH doesn't change because, as you know, pH is a relationship of the concentration of of protons. And so if our pH drastically changed with just the addition of a small amount of acid, we would be in trouble. So instead, our body carries many buffers to prevent that. But some of these protons will eventually bind bicarbonate, and you get your H2O CO3, and this has many fates. Ultimately, it's going to produce CO2 plus bicarbonate again, plus H2O, or the bicarbonate will then be delivered to the kidney where it's peed out. But as this happens, right, your bicarbonate concentration is going to decrease. But what might or might not happen is the anion gap component. These conjugate bases are metabolized or excreted. For example, keto acids are removed by the kidneys, and lactate is removed by the liver. If we have adequate kidney and or liver function, it's possible that the rate of production of this conjugate base is outstripped by our ability to remove it. And so then the anion is going to be constantly excreted out into the kidney by the kidney or metabolized by the liver. And in this case, there's no additional negatively charged molecule that remains in our blood. And so you don't actually get an NAGMA metabolic acidosis. Now, this is a very low level production of the NAGMA, but the pattern that you'll see is that on day 1, you may see your bicarbonate has gone from 21 to 17, but your NAGMA is relatively unchanged. Maybe it's gone from 7 to 8 or something like that, but it's nothing that would alarm you. And then on the second day, you actually see a bicarbonate of 14, and your anion gap is actually starting to go up now significantly. Why is that? Well, as processes get worse, they start to snowball. For example, because we haven't identified the process and haven't fixed the process, well, eventually these anions outstrip the ability for our body to remove them, and these anions actually start adding into our blood and actually creating anion metabolic acidosis. So in summary, if you see a bicarbonate that's decreasing, especially in the ICU, you should always be adding an anion metabolic acidosis at a very low level on your differential to try and so how does this show up in the intensive care unit? Well, it may show up because the patient you're treating for sepsis is initially trying to recover, or maybe you're stabilizing them out, but then you start to see that their bicarbonate is actually decreasing in their blood. Okay, the bicarbonate starts to decrease, and you're like, oh, what's going on? But the anion gap is staying the same as sort of like in this. But what's really going on is perhaps that you're already starting to develop euglycemic decay or a low-level lactic acidosis due to tissue hyperperfusion. And if we caught it on day 1, it's probably more survivable, but logically speaking. But if we wait a few days, maybe it gets out of hand, and by then a lot of injury has been done, and it's hard to overcome. And so that's why I think it's really critical that when we interpret a bicarbonate going down, please think about anion metabolic acidosis just starting as well. Okay, so that's scenario 1. Scenario 2 that we're going to talk about is lactic acidosis. So in lactic acidosis, there's, as you probably all remember, there's the type A versus the type B lactic acidosis. Type A lactic acidosis is the one that we're all used to. This is the shock, the tissue hypoxia, right? And so you have to use anaerobic metabolism because you are unable to get the oxygen you need in order to develop the ATP those tissue need, okay? It's a lack of oxygen. That's the driving factor. But type B lactic acidosis is essentially everything else, and this is an overproduction of lactate for some reason. And so I want to give you a framework to think about that. I apologize for taking us back to biochemistry and maybe a little bit of medical school here, but normally we think of glucose, it converts into pyruvate, and then this combines with acetyl-CoA in order to get into our TCA or Krebs cycle, where we then go to our electron transport chain and develop the majority of our ATP, our energy that we're going to use in order to create all our bodily life processes, for example, right? Okay. Well, it turns out that things that disrupt this process are going to lead to lactic acidosis. And here are some examples. So first I want to introduce the idea of anaerobic metabolism. So this pyruvate alternatively can go through anaerobic metabolism and become lactate. And the key here is that NADH is going to be converted to usable NAD at this point. Okay. Now, processes that block either this step or make us lose, utilize too much NAD plus, which is critical for the TCA cycle, will lead us to increase our lactate production for two reasons. Either the pyruvate starts to build up and this becomes a chemical equation, and since it can't go in one direction, it's shunted into the other direction. Or two, the loss of NAD plus here will lead us to requiring the creation of more NAD plus because it's critical for bodily processes. And so pyruvate is obligated to become lactate in order to achieve that. So let's talk about some things that do that. So the most obvious example that leads to a type B lactic acidosis that we may see in the ICU is alcohol withdrawal. We get patients who come in with significant alcohol withdrawal and they may have an elevated lactate. But I don't want you to be worried about a type A lactic acidosis. Instead, I want you to be concerned about type B lactic acidosis. Why is that? Turns out alcohol and in its metabolism consumes a significant amount of NADH, NAD plus, leading to increased NADH in the body. What does that look like? So you have NAD plus over NADH. This ratio is going to decrease because you consumed your NAD+. Why is that a problem? Well, NAD+ is critical for our TCA cycle to function. And so when we're missing NAD+, we cannot go through our TCA cycle. And what ends up happening is the body then has to create more NAD plus by shunting pyruvate into lactate so that we can create the NAD plus we actually need for our TCA cycle. So ethanol can cause a type B lactic acidosis by forced shunting lactate in this direction. But another way you can do that is there's a molecule called pyruvate dehydrogenase, and it has various cofactors, but one of those cofactors is thiamine. And in our patients with alcohol use disorder, they often are lacking thiamine. And so this means that the pyruvate cannot go in this direction. And so you end up getting a shunting into lactate. So ethanol can cause a lactic acidosis for multiple mechanisms here that we ought to be aware of in the intensive care unit and not necessarily afraid of. Key is all we have to do is supply thiamine and get them out of alcohol use disorder. So please make sure that when patients come with significant alcohol use or even just malnutrition, which is many of our patients, the thiamine is a relatively harmless thing that I think we should probably be pushing for a lot more. Okay, so that's one example. Another example that you might see a significant type B lactic acidosis is in diabetic ketoacidosis. So normally, in order to make our acetyl-CoA, we have to break down our lipids into acetyl-CoA. And then the acetyl-CoA transfers into the TCA cycle via pyruvate. And by going in the TCA cycle, we're able to make ATP like we said. However, in situations where acetyl-CoA is extreme and our TCA cycle perhaps is overwhelmed, you end up getting ketogenesis because an alternate pathway acetyl-CoA can go is formations of ketones or ketogenesis. Now, what triggers acetyl-CoA formation to be in excess to go into and to become ketogenesis? Well, it turns out the balance of insulin and glucagon is key here. Glucagon drives the production of fatty acids and drives ketogenesis. Insulin inhibits the breakdown of these fatty acids and inhibits ketogenesis. Many of our patients in the ICU have bad metabolic disease and they have insulin resistance. And so while in the normal state they're well controlled, in the state where they're critically ill and glucagon significantly activated due to adrenergic drive, whether that is endogenous adrenergic drive or us using things like norepinephrine or epinephrine, the glucagon can then trigger an imbalance in this ratio of insulin and insulin to glucagon, and that drives ketogenesis or ketoacidosis. Okay, and so you get ketone production. Well, it also turns out that if you have so much acetyl-CoA here, right, and the TCA cycle is getting backed up, well, it turns out the pyruvate is also going to get pushed in this direction towards lactate as well. And the reason for that is just that you're overwhelming this side of the equation with acetyl-CoA. The equation I'm talking about is pyruvate plus acetyl-CoA can either go TCA cycle or can go to lactate. If we increase this significantly, yes, we will try to increase our TCA cycle, but in these situations of extreme stress, it also pushes us towards lactate. So in patients with DKA, you will often see the lactate as elevated, and that is a type B lactic acidosis that's coming from DKA in this case, okay? And then there's another big thing that's going to trigger increased type B lactic acidosis, and that's inability to actually utilize the TCA cycle or the electron transport chain. Most of these are drugs that affect and cause lactic acidosis or affecting the electron transport chain, but these might be things like metformin, propofol, linezolid, and more. What these do are effectively inhibit our ability to utilize the TCA cycle, and so then all we have left available is the anaerobic metabolism. We get lactic acidosis. Two more scenarios that I want to talk about. So scenario 3 is going to be the chloride deficient metabolic alkalosis. I'm hoping to make another video separately about decongestion and diuresis in the intensive care unit, but I want to bring up briefly chloride deficient metabolic alkalosis. There is this term, contraction alkalosis, that is probably a misnomer and probably something that makes us understand the pathophysiology incorrectly. Contraction alkalosis is often associated with diarrhea, vomiting, or overdiuresis. And in these situations, we think, the pathophysiology we're maybe taught to think is that, well, this leads to our RAS system being high. And if our RAS system or aldosterone is high, well, aldosterone leads to increased sodium absorption at the expense of potassium and hydrogen excretion into the urine. That's sort of what we're traditionally taught to think, but it turns out that contraction alkalosis is probably not related to the aldosterone entirely, and it's more likely to be associated with the effects on chloride. It turns out in the renal tubule, sorry for my poor drawing here. In the renal tubule, there are cells that have the ability to absorb chloride and then excrete bicarbonate. This transporter is called the pendrin transporter. Pendrin transporter. And what it does is absorbs chloride and allows us to remove bicarbonate. Not all volume contracted patients are actually going to develop quote-unquote contraction alkalosis. What's really happening is that many of these situations, such as vomiting and diuresis, actually lead to losses of chloride. And when you have significant losses of chloride over a period of time, you end up getting hypochloremic compared to your usual state. This hypochloremia leads to an inhibition to then reabsorb chloride because there's not much being filtered into the renal tubule. If you can absorb chloride, well, then you can't start to clear your bicarbonate. And so what bicarbonate starts to do in the blood is starts to increase, and you get a metabolic alkalosis. And this metabolic alkalosis is actually quite dangerous, or at least a dangerous sign if it in itself is not dangerous. The pathophysiology of this is not totally understood, but metabolic alkalosis is often associated with hypochloremia, hypokalemia, and metabolic alkalosis. This is sort of like a trifecta of things that we run into. And the concern here is all of these lead to increased sodium avidity. Why is that a problem? Well, increased sodium avidity means that the kidneys are trying to retain salt, and so the patients become more and more volume expanded. And you start running into these patients who have decreased ability to urinate, increased volume overload, and this compounds our critically ill patients, especially if they have combined mixed shocks in the setting of sepsis and cardiogenic, right? So this is where you start running into trouble. This is actually the basis for why we target this trifecta with making sure that they have increased potassium chloride and maybe even consider 3% saline, because the 3% saline provides chloride. And not intuitively, this actually leads to increased diuresis and perhaps better renal function, maybe even better mortality. And so scenario 3 is me trying to say that in patients that you're diuresing or decongesting at the end of your ICU stay, please make sure that the bicarbonate is not going up. One perhaps very relevant situation is the bicarbonate is so high that patients have a primary respiratory alkalosis. They have a primary metabolic alkalosis leading to alkalemia, and this leads to difficulty liberating them from the ventilator. So when you are diuresing these patients in the ICU, please make sure that you keep the potassium above 4, perhaps even 4.5. You make sure the chloride does not get low. You can do this through potassium chloride or through 3% saline. And then you watch the bicarbonate as a marker for perhaps this worsening physiology, and maybe even consider acetazolamide to correct it. Again, the reason I say consider is because we don't entirely understand if the pathophysiology of diuretic resistance or sodium avidity is coming from the metabolic alkalosis itself. We're quite convinced that it's the chloride deficiency that's part of it, but these two things go hand in hand because in order to maintain electroneutrality, these two things sort of go in a zero-sum direction, right? Zero-sum game. So that's scenario 3, that please don't think of contraction alkalosis as a real thing. Rather, think of it as chloride deficiency, and how you fix that is making sure the K stays above 4 because you're giving potassium chloride, and keep the chloride up. All right, now the final scenario is bicarbonate administration. One thing I've noticed frequently in the ICU is that we're really ginger about giving bicarbonate. It turns out that we probably, you may have remember from our first video that I'm not the biggest fan of giving bicarbonate all the time, but I will do it in situations where pH is incredibly low and the patient's crashing, and I really just want to buy a little bit of time. Not that I think it will change the outcome in itself. And when I do give it, I'm very careful about my calcium. But why can I confidently say that the way we administer bicarbonate is generally very ginger and probably not efficacious? Well, that's because we can actually calculate what's called the bicarbonate deficit. So the bicarbonate deficit is referring to the amount of bicarbonate a patient needs in order to achieve a normal serum bicarbonate or alkali. Okay. And for us to understand how much to give, we need to understand a little bit of physiology, and that's something called the apparent bicarbonate distribution, or ABD, apparent bicarbonate distribution. Now, admittedly, the study was done in a dog model, and so it probably does not perfectly translate to humans, but the physiology is still going to be somewhat relevant to us. So what this says is that the greater our serum bicarbonate, the less of our body that we utilize to buffer our acid-base status. Okay, so we think of our entire body, like 100% of our body, 100% of our cells. Not all our cells are being actively involved in buffering our acid-base status with bicarbonate. But the lower our bicarbonate gets, the more of our body we start to recruit in order to release its bicarbonate to fight our acid-base status. That's maybe an intuitive way of thinking about it. So in a normal state, when our bicarbonate is 24, we roughly have 50% of our body available distributing its bicarbonate. So 50% of our cells in this individual here, so let's just take this half the body. I mean, in reality, that's not what's actually going on, but for the sake of a picture, let's pretend it's this half of the body's cells, and its bicarbonate concentration of 24 are being used in order to buffer any proton that gets into our system. Okay. However, when our bicarbonate starts to drop significantly, for example, we have a really bad DKA or something like that, and the bicarb is 8, it turns out we recruit more of our cells in order to buffer any proton, and that's because, well, there's less bicarb per cell currently, okay? And so we can calculate bicarbonate deficit based on how severe this critical illness is. So let's say this patient has a normal bicarbonate. Well, you probably aren't going to be administering bicarbonate at that point, so that becomes a moot point. But let's say the bicarbonate then drops to 8. Well, roughly somewhere between 70 and 80% of our body is going to be utilized for trying to buffer the acid-base problem that's going on. But that also means 70 to 80% of our body has cells of a bicarbonate that are 8. And our goal is to get this bicarbonate of 8 back to 24. And so we can calculate a bicarbonate deficit. How we do that is, well, we know the bicarbonate deficit, so the serum bicarbonate is 8, and we want to get it back to 24. So for the cells that are actively being utilized for the process of acid-base management, they have a deficit of this amount. 24 being normal, 8 being the concentration of the bicarbonate in the cells. And then we need to multiply this by the actual percentage of the body that's being part of this acid-base management. So this is going to be our total body, this is going to be our weight, rather. Our weight in kilograms times the percentage that we've deemed to be part of the acid-base management. So, for example, with a bicarbonate of 8, roughly 70 to 80% of our body is involved in acid-base management. If I take a 100 kilogram individual and I say roughly 0.7 of their body is being utilized to buffer the acid-base status, but each of these cells is missing 24 minus 8 number of bicarbonate, well, then this would help us calculate out 16 times 70 is the amount of bicarbonate that our body is missing, right? And this is an actually insanely large number, but not an unrealistic one, where this patient is missing 1120 milliequivalents of bicarbonate. So when you give 1 amp of bicarb, your 50 MEQs of bicarb, you're not really touching this, right? It's just bouncing off, and then you know, the ketoacidosis, lactic acidosis is regenerating that gap very quickly. And so this is why I encourage you that if you're really going to correct the bicarbonate, correct it hard and fast with calcium as well. So what I mean by that is give 3 to 4 amps of bicarb at a time in these types of situations, and then make sure you chase it with some calcium, whether that's calcium chloride or calcium gluconate. But, my point being here, again, that if you're going to fix the bicarbonate deficit, fix it aggressively. This is how one would calculate it. But if you're not going to calculate it, at least recognize that it's probably a lot larger than you think it is. Okay, well, that's the end of this video. Thank you so much.